I'm Jerry Jones. I really don't own the Dallas Cowboys. I get asked that all the time. And I have no disclosures, so let's move right along. We have a lot to cover. Today's topics are going to be the earliest signs of acute epicardial ischemia, commonly known as STEMI. What we actually treat are ischemias. We don't treat infarctions. Infarctions are completed, they're dead. We treat ischemias where we have a chance for myocardial salvage. The next topic I'll talk about will be reciprocal changes. Most people have heard of reciprocal changes or know a little bit about reciprocal changes, but you probably don't know quite as much as you think. Reciprocal changes can be very good because they can help us come to a medical decision even when the ECG looks very, very difficult. The third topic is the dangers of lead AVL. Anyone who has been interpreting 12-lead ECGs for any length of time should have developed a very healthy respect for this lead. If you haven't, you will. So let's get started. First, let's be on the same page. On the left is infarction, the Q wave. On the right is acute epicardial ischemia. We have ST segment elevation. We have large T waves, but that is not infarction. That is ischemia. That is living heart muscle and a chance for myocardial salvage. The earliest signs of any kind of ischemia, whether it be epicardial or subendocardial, are hyperacute T waves. Now, I want to set the record straight. Hyperacute T waves are wide and prominent. They are not necessarily tall. So many times when I ask my students to describe hyperacute T waves, they'll talk about very tall, very peaked T waves, and they're essentially describing the classic hyperkalemic Ts. But hyperacute Ts are wide. They are always wide. They are never thin, I'm sorry. All of these are hyperacute T waves. As you can see, the ones in the middle are very tall. But in V5 and V6, they're not tall at all. But all of them are wide. Hyperacute T waves will always be wide. There are subtle changes in the STT segments that you need to know about. But let's start with the normal down there on the right. The ST segment begins at the J point and immediately and gradually has this upslope into the T wave. That is an upward concavity. When we talk about ST segments and T waves in electrocardiography, we're always talking about concavity, convexity. We always discuss this in terms of an upward orientation. We're not worried about this being a downward convexity. It is an upward concavity. It blends imperceptibly into the T wave. You cannot see where that ST segment ends and that T wave begins. The T wave then makes a more abrupt return to the baseline. So the T wave normally is asymmetric. It is asymmetric. Now let's look on the left. Let's look at those four complexes there. And the ST segments, flat, 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 and flat. Let's look at the T waves. They are perfectly symmetrical. You look like you're looking at the pyramids in Egypt. They're perfectly symmetrical. Now let's look at the junction where the ST segments and the T waves meet. It's very well demarcated. You could take a very thin ballpoint pen and draw a line exactly where the T wave begins, where the ST segment has ended. A myth that I want to dispel at this point, if you ask a lot of people, how would you describe the ST segment in an acute epicardial ischemia, a STEMI? They're going to tell you, well, it's a very upward convex ST segment, ST elevation, upward convex ST segment. Well, that's right, but this is also a STEMI. You can have upward concavity with a STEMI. You still have ST segment elevation, undoubtedly, but either one is a STEMI. No one really knows why they present either way, but both of them are STEMIs. In fact, the upward concavity can be present up to 45% of the time. I want to introduce you to a concept called Jones's sign. If we look at the normal complex over on the far left, which we just saw a while ago, and then we compare it to the far right with the ST elevation and the beginning of an upward convexity, for that ST segment that has an upward concave appearance to develop into that ST segment with an upward convex appearance, it's going to go through this middle section, this transitional zone. You're going to have a straight ST segment beginning at the J point, extending right up to the peak of the T wave. That is Jones's sign. It's fleeting. It indicates an ST segment that is on the move. And if you happen to do the ECG right at that point, this is what you're going to see. Where it really helps is when you have very low voltage in the limb leads. And it can be very difficult, you're going to see in just a moment, assessing the ST elevation in those leads. But with this Jones's sign, it really indicates to you that that's where a problem lies. Here is such a situation. Let's look at a lead 3. You can see no ST segment there, no QRS segment there because the QRS is virtually isoelectric. In lead AVF, it's almost isoelectric, but in both those leads, you see a perfect Jones's sign, that straight ST segment beginning at the J point and extending to the peak of the T wave. That is an ST segment on the move. If you had a magnifying lens and looked very closely at the AVF, for instance, you would see ST elevation there. You have to remember that repolarization is proportional to depolarization. To accept that it has to be 1 millimeter elevation or 2 millimeters elevation before you can call it a STEMI is really ludicrous. And there is a movement afoot right now to change this whole concept from a STEMI to an OMI, obstruction myocardial infarction. Now, let's talk a little bit about reciprocal changes. And these are the changes that can really help you when an ECG is very, very difficult to interpret. And you're going to see a couple here. The pro for reciprocal changes is that they're an excellent confirmation or validation of your suspicion of an acute epicardial ischemia. But there are a couple of issues you may not be aware of. Number one, reciprocal changes can appear well before any ST segment elevation. And two, they may be much more obvious or impressive than the actual primary change of ST segment elevation. When we see reciprocal changes, we're looking at ST segment depression, and the confusion develops, is this a reciprocal change or is this subendocardial ischemia? Well, when we look at the leads showing what may be a reciprocal change, that would normally indicate other leads that we need to focus on for the ST elevation, which could look like, again, an upward concavity or an upward convexity. ST elevation localizes, and this is a term we use more and more nowadays in electrocardiography. ST elevation localizes. If you have ST elevation in leads 1 and AVL, you have a high lateral, nowadays we call it basolateral STEMI. We know exactly where it is. ST depression that is due to a reciprocal change also localizes in the sense that it will point away from itself directly to where the problem is. So if we get an ECG that has ST depression in 2, 3, and AVF, we're going to immediately look in AVL. So ST elevation localizes, ST depression, when it is a reciprocal change, will localize by pointing to where the problem is. Now, ST depression that is truly due to subendocardial ischemia does not localize, period. If you have a patient with subendocardial ischemia with ST depression in leads 2, 3, AVF, you can't say that they have inferior subendocardial ischemia. All you can say is that they have subendocardial ischemia. You don't know for sure where all that ischemia is located. So ST depression due to subendocardial ischemia does not localize. The best you can say is that it's there, but to say that it's lateral subendocardial ischemia or inferior really makes no sense. This leads us to Jones's rule. This is a rule that I began abiding by many years ago, and many of my students have contacted me about how they avoided issues, missed myocardial infarctions by following this rule. In a patient with chest pain that is reasonably compatible with an acute coronary syndrome, this is the chest pain, crushing, pressure-like pain, radiating to the arms, neck, jaw, nausea, diaphoresis. Any ST depression on that ECG should be considered a reciprocal change until proved otherwise. A reciprocal change to an acute epicardial ischemia or STEMI until proved otherwise. Bearing in mind that the ST elevation may not have appeared yet, and that even if the ST elevation is present, the reciprocal change may be a lot more impressive. And you're going to see an episode or an example of this in just a moment. For instance, if you have a patient come in with chest pain and they have ST depression at 2, 3, and F, their chest pain is very compatible, it's acute, all the typical signs of an acute coronary syndrome, but you just don't see anything in 1 and AVL. What do? Well, you don't call it angina and send them home or send them upstairs. You repeat that ECG, that 12-lead ECG, about every 10 or 15 minutes. Within the hour, you're probably going to see a marked change develop. I'm going to show you an ECG in a little bit where this was not done. How many subtle signs of epicardial ischemia do you see here? Well, let me answer that for you. Look in lead 1. We have a wide symmetrical T wave. Let's look over in V1 through V6. Wide T waves, some of them are not symmetrical, others are very symmetrical. If we look in lead 2, that's almost like the complexes we looked at a little bit earlier. It has a flat ST segment, it has a very symmetrical T wave, and a well-demarcated junction between the ST segment and the T wave. Now we have ST segment depression in 3 and AVF. Jones's rule, in a patient with signs of acute coronary syndrome, any ST depression is a reciprocal change until proved otherwise. And we can consider the changes in lead 2 to be a reciprocal change. Henry Marriott was adamant about that. It doesn't have to be ST depression. It can look like that. Well, if we have reciprocal changes in 2, 3, and F, where do we look for the primary change? We're going to look in AVL first and 1 also. In AVL, it's hard to see up here, but there is a subtle ST elevation. But more than that, there is Jones's sign also, a straightening of the ST segment from the J point to the peak of the T wave. And this indicates an ST segment that's on the move. If we look up in lead 1, we don't see any ST segment elevation, but we do see a wide, very symmetrical T wave. So something's happening there too. Well, let me go back. One thing I want to point out, the ST depression in 3 and AVF can catch your eye immediately, but how long would you have to look before you saw the ST elevation in AVL? So this is an instant where the reciprocal changes are a lot more prominent, a lot more impressive than the actual primary change. Don't be distracted. The problem lies in AVL, not in 2, 3, and F. Some pearls about reciprocal changes. Again, don't confuse them with subendocardial ischemia. It might be subendocardial ischemia, but you have to prove that. Assume in any patient with acute chest pain that the changes of ST segment depression are reciprocal changes. Reciprocal changes may appear before the primary changes of ST elevation, Always look for the reciprocal changes, but again, don't be distracted by them. The real problem is the ST elevation, and sometimes it's hard to see the ST elevation, but the reciprocal changes will point the way for you. AVL is the most dangerous lead. When I was training in internal medicine, I trained in an institution where we had a huge cardiology department, and all the cardiologists had to spend a month doing general medicine attending routines. So almost all my attendings during my rotations were cardiologists. And one of them always said, it shouldn't be named AVL, it should be named EVL. And I found out why later on. Again, if you haven't developed a healthy respect for this one lead, you will. The most common cause of malpractice litigation in this country is failure to diagnose. The disease that we fail to diagnose most is acute myocardial infarction, and most of those are because we fail to pay close attention to lead AVL. If you're going to miss an acute MI, this is where it's going to happen. Right there. It's going to involve AVL. Either you will not see a subtle ST depression there indicating a problem in the inferior wall, or you're not going to see a very subtle ST elevation. Why is it so difficult? Well, most of the mean QRS axes will cluster around plus 60 degrees. This is just the normal way that our heart depolarizes in the ventricles. But plus 60 degrees is the lead 2 axis, and AVL is perpendicular to the lead 2 axis. So very often, all the deflections in AVL are going to be very small and very difficult to see. Here's an example. This would be very difficult. I would not expect anyone to jump in and immediately see what's going on there without some years of experience, unless you remember Jones's rule. If this patient came in with chest pain, any ST depression is a reciprocal change until proved otherwise. We see subtle but definite ST depression in 2, 3, and AVF. Those leads will point to 1 and AVL. Now, when we look in 1 and AVL, it's really hard to say that there is ST segment elevation. There was. What we have left now is simply an upward convex ST segment. In this case, it's not what we see, but what we don't see. What we don't see is an upwardly concave ST segment that blends imperceptibly into an upright T wave. This is a subacute MI. This patient has already begun to reperfuse. We have the T wave inversions in 1 and AVL. That indicates the beginning of reperfusion. The MI is done. It's over with. But we still see the ST depression in 2, 3, and F that points out to us very clearly where this problem is. This is the same thing enlarged a little bit, and you might be able to see a little bit more clearly the ST depressions. Again, don't worry so much about the complexity of what's happening in 1 and AVL. The reciprocal changes in 2, 3, and AVF are going to save you here. This is an ECG that I have a lot of mixed feelings about. This is a patient that was sent out with a diagnosis of angina. She was seen initially by or only actually, by a third-year internal medicine resident who did not appreciate changes going on there. Now, I don't know how many of you 30 minutes ago would have appreciated much going on in this ECG, but this is a 58-year-old woman that came into the emergency department complaining of sudden onset of chest pain, and it was classic chest pain. The first thing I would see when I look at this is The first lead I always look at anymore is AVL. And in AVL, I would see ST depression. So I have to ask myself, why is there ST depression in AVL? And for the most part, only AVL. Are we going to have a subendocardial ischemia that's localized just to that one lead? Very unlikely. Let's go back to Jones's rule. Any ST depression in a patient with an acute chest pain onset compatible with acute coronary syndrome is a reciprocal change until proved otherwise. Well, if we have a reciprocal change in AVL, where is the primary change? Well, the primary change should be in 2, 3, and AVF. Not really spectacular there. The resident missed it. If you look closely, there is ST elevation in all 3 leads. It's subtle, but it's there. But also, more importantly, Jones's sign is there as well. So now we have a patient with acute onset of chest pain compatible with acute coronary syndrome. We have ST depression in AVL and subtle changes in 2, 3, and AVF. This is a patient having an acute inferior myocardial wall infarction or acute epicardial ischemia at least. She was given a prescription for a long-acting nitrate and sent home. Fortunately, she went immediately to another hospital through the emergency room. They repeated the ECG. By then, what they saw on their ECG, she went directly to the cath lab. So the bottom line is, if you're still not 100% sure, repeat the ECG. They're not that expensive. You just leave them hooked up to all the leads and repeat it about every 10 or 15 minutes. AVL is the most dangerous lead you will deal with. As I said before, if you're going to miss an ECG, acute MI on an ECG, it's going to involve this lead. I can almost promise you. Never put down a 12-lead ECG until you know you have thoroughly looked at lead AVL, thoroughly and carefully. Now, just some parting thoughts here. Hyperacute T waves are not always tall, but they are always, always wide. Reciprocal changes may appear before the primary ST elevation. If you're still suspicious that this patient could have an acute coronary syndrome, you simply repeat the ECG about every 10 or 15 minutes. Jones's sign, don't forget about straightening of the ST segment in the correct context. If I saw that in a 30-year-old patient who had a very healthy lifestyle and no complaints whatsoever, I wouldn't pay any attention to it. Everything we look at and inspect in ECGs is always in the context of the patient's condition. Jones's rule. Remember Jones's rule, and even the worst, toughest ECG you may have to interpret, Jones's rule can save you there. And that, again, is in the context of a patient with acute onset of chest pain that's compatible with acute coronary syndrome. Any ST depression is a reciprocal change, change until proved otherwise. Again, you have to bear in mind that it may appear before the primary change, and even when the primary change of ST elevation is there, as you saw earlier, the reciprocal change can be a lot more impressive. Watch out for AVL. Inspect it very, very carefully. And after you've done that, inspect it again. We're finished here.